Mr. Chairman, my friends, when we talk about friends, we mean that the friend is the person who provides help to the other. While when we say that one person is an enemy, it means that it causes harm to the other person. So now we have two parties here, Ercp, and we have the pancreas. Are they really friends? Does the Ercp provide help to the pancreas? Or it's an enemy that it causes very harm to the pancreas? This is what I'm going to cover in the next 20 minutes. Well, actually, Ercp is a real sincere friend to the pancreas because, as you can see here, there are several indications: acute gallstone pancreatitis, drainage of communicating pancreatic pseudocyst, chronic pancreatitis with recurrent acute pancreatitis due to either stones, stricture, rupture, and Pancreas Division. And lastly, something new now is the pancreatic duct endoscopy, as well as the intraductal ultrasound when there is a suspicion of a carcinoma or IPMN. Now, in acute biliary pancreatitis, Ercp is the procedure of choice with sphincterotomy that has to be done within the next 72 hours of admission, especially if there is one of the following items. Number one, if there is a CVD stone that's well seen on ultrasound or non-invasive modality. Number two, if bilirubin is elevated. Number three, if the liver chemistries are getting worse. Now, in certain indications, it has to be done much earlier than 72 hours, which is 24 hours if there is concomitant cholangitis or if the pancreatitis is severe. In that case, it is urgently need to be done. This is a young lady with acute pancreatitis admitted 24 hours after the incidence of pancreatitis. As you see here, she has a high bilirubin and elevated liver enzymes. So we decided to go ahead and because of the pancreatitis and the bulging papilla, we decided no need to bother the orifice of the papilla and to go ahead with the supra-orifice pre-cut. As you see here, part of the stone started to appear, and you go at 11 o'clock, as Ibrahim said, and you can now appreciate the stone started to be seen. Now, I decided, because it was hooked deep, and so I took the roof of the orifice and cut it upward, and as you see now, the stone started to come down, and it came down. Now, the patient recovered in 24 hours, discharged 72 hours after admission without any complications. The second indication is to drain a pancreatic pseudocyst. We should say that only symptomatic pseudocyst should be drained, which means either infected or causing abdominal pain, vomiting, early satiety, obstruction to the CVD, or if it's progressively enlarging. Otherwise, the pseudocyst should not be drained. The old theory, which says that larger than 6 centimeter, a cyst that has been for more than 6 weeks, it should be drained. It's not valid anymore, and if it is asymptomatic, it can stay without any potential harm to the patient. Now, if the lesion is solitary, communicating with the pancreatic duct, and the size is less than a centimeter, and its content is homogeneous, then you can go transpapillary through the orifice and drain the pancreatic pseudocyst directly into the through the papilla. On the other hand, if the cyst is too large, or there are more than one cyst, if it's infected or non-communicating, or it has heterogeneous contents, in that case, EUS-guided transgastric or percutaneous drainage need to be done. This is, for example, one of the cases here of a patient who came with recurrent pancreatitis, and we found on the MRI and MRP that he had a pancreatic pseudocyst in the tail of the pancreas communicating with the pancreatic duct. And when we did the Ercp, there is a stricture here, and this is the cyst here. The stricture was dilated with the balloon dilator, and then we put a 10 French, homemade 10 French pancreatic stent. It's very important to keep in mind that pancreatic stent has to have multiple side holes, otherwise it will cause pancreatitis, not like the biliary. And you see gush of fluid came down to the duodenum, and then this is the 10 French stent. For the interest of time, I'm not going to show video images, although they are available for anyone who wanted, but I'm going to show still images. Next is the recurrent acute pancreatitis due to either stones, stricture, rupture, or pancreas division. All these problems, the Ercp is the best modality to solve. Stones, pancreatic sphincterotomy with balloon dilation for any possible stricture, or the duct, if it is smaller than the stone, then it needed to be done before you attempt to remove the pancreatic stone. Now, if the stone or stones are large or embedded in the pancreatic duct, then they can be removed, and they cannot remove them even with a mechanical lithotripter. In that case, you can either put a nasopancreatic tube and use biplane fluoroscopy with extracorporeal shockwave lithotripsy, or you can go directly with the presence nowadays with a spyglass directly to the pancreatography and fragment the stone with the electrohydraulic lithotripsy or with the pulse laser. All these modalities proven to be very safe and very effective, with success rate ranging from 75% up to almost 100%, and a very minimal complications of less than 6%. This is the spyglass here, and this is how you see the stones that can be fragmented with the electrohydraulics. Now, this is another case. Here is a 47-year-old man with 5 years history of recurrent acute pancreatitis. And when we did CT scan, it showed the pancreatic duct to be dilated with calcified objects. And when we did the Ercp, there are two large stones here, one in the tail and one in the mid-body, with significantly dilated pancreatic duct. So we did pancreatic sphincterotomy with balloon dilation up to 8 millimeters. And then with the mechanical lithotripter, we managed to catch this middle duct-located stone and removed it, but the large one in the tail of the pancreas, it could not be removed. It could not be trapped by the baskets. So we put a nasobiliary tube, nasopancreatic tube, and then we cracked with the extracorporeal shockwave lithotripsy into several fragments, and then dilated further with 10 millimeter balloon dilator, and then with the mechanical lithotripter, we removed all the stone fragments, and the patient did very well, discharged from the hospital. So far, I've been following the patient for 7 years. He's totally asymptomatic. Now, what about if there is a pancreatic stricture? We know that pancreatic stricture is the cause of recurrent acute pancreatitis, and even in chronic pancreatitis is the cause of pain and exocrine insufficiency. Now, the stricture might be associated with stones, pseudocysts, or even malignancy. So you have to keep in our mind the potential for malignancy, and to brush the stricture anytime that you try to dilate as well. Endoscopic management of the stricture is done by balloon dilation of the stricture, followed by insertion of pancreatic stents. Now, it has to be the biggest stents that you can reach, and you can keep changing the stents every 3 months for a period of 1 year. And with using this technique, you see the success rate ranging from 72 to 100%, with complete relief of pain in almost the same thing, and even 3 years after removing the last stent, the pain relief was achieved in almost half to three-quarters of the cases. Now, if there is a pancreatic duct disruption here, which is causing then leak of pancreatic juice, which may lead to pancreatic pseudocyst or pancreatic ascites, in that case, transpapillary stenting proved to be very effective. You don't need to bridge the ruptured location. It's just enough to break the pressure gradient barrier between the pancreatic duct and the duodenum by placing a stent, and that will end up in the healing of the stricture of the leak, and the stent can be removed after 2 to 6 weeks later. Now, this is a young boy, 9-year-old, after a blunt trauma. Was playing with his bicycle. The steering rod of the bicycle hit his abdomen, developed massively large pseudocyst, 9 centimeter. With this case, it's not safe to go through the papilla. In that case, we use the EOS-guided technique. We drain the pancreatic cyst. As you can see here, this is a guide wire, 10 millimeter balloon dilator, followed by 2 double pigtail 10 French stents placed. After that, the patient did very well, discharged a few days later on, and when he came after 9 weeks, no more fluids, no more pseudocysts, and these are the stents. So after we removed them, and then we did pancreatogram, you see the pancreatic duct is completely normal. So it seems that once you relieve the pressure by allowing the leakage to be drained, then the pancreatic rupture site will seal off, and we removed these pancreatic cystic stents, and the child did very well without any symptoms. Next, Pancreas Division. What do you mean by? I think all of you know what's meant by Pancreas Division. When it's the dorsal duct, which is the major duct, drains into the minor papilla and doesn't communicate with the ventral duct that drains into the major papilla. In that case, high pressure of pancreatic juice finds itself in a very thin orifice, which will lead to recurrent pancreatitis. It's normally seen, astonishingly, in 7% of autopsies. However, only 5% of Pancreas Division cases develop recurrent pancreatitis, and there are some studies which showed that it has those kind of patients, they have some problem with the genetics related to cystic fibrosis. How do we manage Pancreas Division? In the past, there used to be a surgical, but it has a lot of morbidities and it's too invasive. Endoscopic techniques, the old techniques, which is dilation of the minor papilla and putting stents, has been found to have a lot of complications. Most of the people nowadays go with the minor papilla sphincterotomy, either directly or going into 10 to 11 o'clock location with a regular papillotome, or by placing a 3 to 4 French pancreatic duct stent and use it then as a guide to perform a pre-cut with the needle knife. Both techniques are safe enough and have the same efficacy, although most of the endoscopists prefer to put the pancreatic stent and do a small pre-cut, about 3 to 4 millimeters in length and 2 to 3 millimeters in depth. And then after 3 to 4 weeks, the pancreatic stent can be removed and the patient most likely will be cured. Now, but direct pancreatoscopy, of course, with the spyglass or other small scopes, you can use them when there is a suspicion of malignancy or IPMN, and also for the management of pancreatic duct stones with the laser or electrohydraulic lithotripsy. IDUS, which is intraductal ultrasound, it's a thin probe that can be passed over the guide wire inside the pancreatic duct, which is also very helpful in confirming the type of nature of the stricture, if there is still suspicion, and there is suspicion of cancer, or even to look for tiny endocrine tumors in the pancreas that are near to the pancreatic duct. Now, we talked a lot about the friendship. Now, ERCP, on the other hand, may become very fierce enemy. It may cause very bad pancreatitis, which is the most serious complications of ERCP, as Ibrahim talked to you about it before. This is a summary of a meta-analysis of 21 studies on almost 17,000 patients, and the incidence of pancreatitis ranged between 3 to 4%. Now, severe pancreatitis, luckily, is very rare, is about 0.4%, and only 18 deaths, which is 0.1%, was observed out of 17,000 cases. So it's a really serious problem. What's the cause of pancreatitis? Either mechanical injury from repetitive attempts, as Dr. Ibrahim mentioned very nicely, maximum 10 attempts, should not exceed 10 attempts. Hydrostatic injury may happen from over-injection of the contrast, or chemical or allergic reaction to the contact, or infectious pancreatitis if the equipments are not well disinfected, and also thermal injury, the post-sphincterotomy. If you keep cooking inside and you don't continue with the cut, then the incidence of pancreatitis become much more. Responsible factors, the most important, as Ibrahim said, operator-related factors, which are inadequate training or lack of experience. Again, centers that they do 40 or 50 cases a year, this is not the place to to keep your skills good enough to prevent pancreatitis. You have to do 200, 300, or 400 per year in order to keep your skills very well to avoid complications. Now, patient-related factors, it's been found that young, especially female, those with a normal bilirubin or with a sphincter of Oddi dysfunction, or those who have recurrent pancreatitis, most of these patients may have higher chance to get pancreatitis than other patients. Procedure-related factors, difficult cannulation, pancreatic duct injection, sphincter of Oddi manometry using a continuous flow technique, pre-cut sphincterotomy if it's not properly done, and minor pancreatic sphincterotomy, or balloon dilation, sphincteroplasty, or ampulectomy. How do we prevent pancreatitis? Of course, number one, proper training and enough experience. Number two, avoid using ERCP as a diagnostic modality. Use it only to treat your patient's problem. Over-the-guide wire technique may facilitate easier to go selectively into the common bile duct. It doesn't show that it decreases the pancreatitis unless the limitation was limited to less than 10 attempts, then it may minimize the incidence of pancreatitis. Electrocautery, whether to use a pure pre-cut versus blend current, there was no significant difference between them, but the incidence of bleeding was higher in the pure cut, so we still depend on blend current to do sphincterotomy. Now, PD stent, this is very important, has been shown to be very effective in preventing pancreatitis, especially if you have attempted several times to cannulate, or if you fail and you want to do pre-cut and the papilla is not bulging, as I'm going to show you. Now, what about pharmacotherapy? It's been found indomethacin suppositories and other type of NSAIDs, they may abort or prevent the development of pancreatitis in patients post-ERCP. Therefore, they can be used in centers which they observe high incidence of pancreatitis, or if the patient is considered a high-risk individual like young, female, normal bilirubin, etc. This is one of the cases. You see the papilla is small, it's not bulging, and the cannulation continuously failed to go into the common bile duct. For this case, we put a pancreatic stent. I see the needle here started to cut, and then the stone was removed at ease. In summary, ERCP is an intimate friend to the pancreas that helps managing several disorders: acute gallstone pancreatitis, drainage of communicating pancreatic pseudocyst, chronic pancreatitis, and recurrent acute pancreatitis due to stones, stricture, rupture, leak, or pancreas division. Pancreatic duct endoscopy is still in its infancy, but it can be helpful when there is suspicion of carcinoma or IPMN, or when there is a small endocrine tumor that could not be detected with a CT scan. And we have to be aware that it may become very bad enemy to the pancreas and may be very harmful if there is no strong indication to do ERCP, and if we don't care about the risk factors like doing the procedure by inexpert persons, post-ERCP pancreatitis then may happen. Thank you very much.